Good afternoon, everybody. Welcome to today's acid-base conference. I'm going to pick up from last month's talk, which dealt with how to make an acid-base diagnosis. So we'll review some of the concepts that I talked about before, and then we'll delve into some of the cases that exemplify the ideas that I'm going to talk about. So the problem people have when they're confronted with all the numbers from the lab is which numbers should you focus on to make an acid-base diagnosis, and it's confusing. We have the total CO2 from the chem panel. We have the bicarbonate that's calculated from the blood gases. We have the pH and the PCO2. But the rule is you should look at the numbers that are in red. Remember that the total CO2 is made up mostly of bicarbonate. And so you shouldn't call it bicarbonate because it's not only made of bicarbonate. You should only use the word bicarbonate when you're talking about the calculated value from the blood gas machine. But because they approximate each other, they're basically interchangeable in most clinical cases. So you could focus on either. If you don't have the blood gases, then focus on the total CO2. It's a surrogate for bicarbonate. But remember not to call it bicarbonate. And you have to decide in your mind once you focus on it to answer one of these 3 points. Is it normal? Is it increased or is it decreased? If it's decreased, or if you have the bicarbonate and it's decreased and you happen to look at that, then you have a choice of one of three acid-base disorders. It's either a metabolic acidosis, or it's an acute respiratory alkalosis or chronic respiratory alkalosis. Remember, the respiratory acid-base disorders, we divide up by time. We call it acute or chronic. We don't do that with the metabolic acid-base disorders. You should note also that in all three acid-base disorders, not only is the total CO2 or bicarbonate decreased, but the PCO2 is also decreased. All three have a drop in the bicarbonate and the partial pressure of carbon dioxide. If they go in opposite directions, then you know a priori you don't have a simple acid-base disorder. In all the acid-base disorders, whether the bicarbonate is down, as in these three examples, or whether it's up, as in the subsequent slide that I'll show, the PCO2 always goes in the same, is changed in the same direction. So the minute your mind sees them going in opposite directions, you know you don't have a simple acid-base disorder, even without figuring out what the acid-base disorders are. It's just a clue. So we have a drop in the total CO2 or bicarbonate in all three, and we have a drop in the PCO2 in all three. So how do you distinguish the three of them? And we do that by assessing the change in the bicarbonate from its normal value in relationship to the change in the PCO2 from its normal value. And those proportionalities, the so-called delta bicarbonate compared to the delta PCO2, is what distinguishes the three disorders from each other. They all have a different ratio. And again, we're not looking at the pH, as I mentioned in the last talk and previous talks, because if you look at the pH and decide, is the patient alkalemic or acidemic, or as some people say, acidotic and alkalotic, then you're not going to be able to distinguish these disorders from each other, because that's not enough information to make the diagnosis, or to even diagnose complex acid-base disorders when more than one is present. The only way to definitively know what's going on is to assess the change in bicarbonate from its normal value in proportion to the change in the PCO2 from its normal value. That's what definitively distinguishes these three diagnoses from each other. So in metabolic acidosis, we have a drop in the bicarbonate for whatever reason. Either we had a proton load that converted bicarbonate to carbon dioxide, and that was excreted, or we had a loss of bicarbonate in the stool or the urine. But for whatever reason, the bicarbonate decreased. And what happens is the PCO2 also decreases. So in metabolic acidosis, you have a drop in both parameters. We call the drop in the PCO2 the respiratory compensation or the compensatory response. And the change in each of these from normality is known. It's empirical from studying a large number of patients. It's known that for every 10 fall in the bicarbonate, the PCO2 falls about 12. It falls a little more than the bicarbonate fell. Some people use the Winters formula if you want to use that, but we tend not to use an equation for the other acid-base disorders. So if you want to do things symmetrically, then you would have the same approach to all of them, where you just look at the delta for each of these parameters and know what it should be compared to what your patient has. So, for example, if the original bicarbonate was 24 and it fell by 10 to become 14, you'd expect that the PCO2, if it started at 40, would fall to 28. So if you see a patient with a bicarbonate of 14 and a PCO2 of 28, that's compatible with what's called a compensated metabolic acidosis. So the proportion is 1.2 to 1 or 12 to 10, or you can invert that and say 10 to 12, whatever number you want to talk about first. But the concept is that the PCO2 in absolute terms falls a little bit more from its original level than the bicarbonate fell. And this is what you should see if you have a compensated metabolic acidosis. And again, you can remember 5 to 6 if you want. For every 5 fall in the bicarbonate, the PCO2 falls by 6. It's the same. You're saying the same thing. Now, in metabolic acidosis, we also divide them up by whether the anion gap has changed or not. And the anion gap concept is just an extended concept or a subset of the concept of electroneutrality. All solutions with ions are electroneutral, where the positive charges are equal to the negative charges. So we put all the positive charges in blood on one side and the negative charges on the other. We include IgG among the positive charges. Remember, it's positively charged. That's why the anion gap changes in multiple myeloma when you have IgG present. There are also non-ions that we call organic anions. They're not simple ions, they're organic ions, anions, and that's what the OA stands for here. But when we measure the anion gap clinically, we only use certain parameters. We take the sodium, chloride, and bicarbonate, and we leave out everything else. So if you just move the terms to the other side, you end up with the sodium minus chloride plus bicarbonate is equal to the unmeasured anions minus the unmeasured cations. Everything that's negative here we're calling unmeasured. So we're not including phosphate here, we're not including sulfate, we're not including organic anions, so they're all in the UA minus term. And in the UC plus term are all the things that we're not including on the left side here, such as calcium, magnesium, IgG, even potassium we tend not to include. So those are all here. So what this tells you conceptually is that this difference can change either because you had a change in the unmeasured anion concentration or the unmeasured cation concentration or both. For instance, in multiple myeloma, you have an increase in unmeasured cations. So the IgG goes up and you measure that change because the IgG goes up with chloride going up, right? The IgG can't go up alone. You have to maintain electroneutrality. So on this side, it's the IgG going up, and on this side, it's the chloride going up. And so the difference decreases on this side because the UC plus went up, and the difference goes down on this side because the chloride went up. Um, that's an example of the anion gap changing. We tend to think of it clinically as being organic anions going up, such as beta hydroxybutyrate, acetoacetate, lactate. Those are the more common reasons the anion gap increases. But remember, they can go in either direction. For instance, albumin is negatively charged, and when albumin goes down or up, it can change your anion gap here. It's in this term. So remember that in metabolic acidosis, especially endogenous sources of metabolic acidosis, the proton tends to come in with an organic anion, and the anion gap will then go up, as opposed to other causes like diarrhea or pancreatic fistula or gallbladder fistula or renal tubular acidosis, where you don't have an organic anion floating around. what you have is the bicarbonate changing, and then the chloride changes in the opposite direction, such that the total of these two things stays the same, and that's why the anion gap doesn't change. So in a non-gap metabolic acidosis, the chloride is varying inversely with whatever the bicarbonate is doing to maintain electroneutrality. When you have an anion gap metabolic acidosis, you have the bicarb and the unmeasured anion changing inversely to maintain electroneutrality. Now, causally, why they both change is different. Well, the anion gap going up is not causing the metabolic acidosis. It's just a reflection of the anion that came into the bloodstream with the proton. The proton is what's causing the metabolic acidosis because it's what's binding to bicarbonate and lowering it. The anion gap is going up because the proton happened to come in with an anion. Just like if you gave someone a hydrochloric acid drip, the chloride is not causing the metabolic acidosis. It's the proton. The same with an organic acidosis. So in metabolic acidosis, we decide two things. One, whether it's compensated. In other words, did the PCO2 change as we predicted would? 12 fall for every 10 fall in the bicarbonate, as I showed on the previous slide. And did the anion gap change? Not for causal reasons, but we just have an easier way of distinguishing the cause of the metabolic acidosis. That way we don't have to think of as many causes. If it falls into an elevated anion gap or normal anion gap group, we can only think of the causes within that group. That's why, for a utilitarian reason, we divide it up by the anion gap. Now, the bicarbonate can also decrease, not because of a metabolic acidosis, but because of the second and the third reason I showed on the previous slide. You could have an acute or a chronic respiratory alkalosis. And what happens there is that the PCO2 drops initially, and then you get a fall in the bicarbonate subsequent to the fall in the PCO2. The reason for that acutely is not organ related, it's the bicarbonate buffer reaction. So the bicarbonate buffer reaction is shown here, where carbon dioxide and water forms carbonic acid, which then breaks up into a proton of bicarbonate. This reaction can go in either direction if you shift the equilibrium. And what happens is, just like when you open a bottle of Coca-Cola, the PCO2 drops and you shift the reaction towards the carbon dioxide side. And when you do that, you drop the bicarbonate. You consume bicarbonate in this reaction. So this is what we call acute respiratory alkalosis. It's no different than opening a carbonated drink and watching the carbon dioxide drop and the bicarbonate drop in the solution. The same thing happens in your body. And we call that acute respiratory alkalosis because the whole process is over in a very short period of time. So it's called acute. And this is shown pictorially here, where we have two curves here. The top is the PCO2 versus time, and the bottom is the bicarbonate concentration over time. So let's say we have the PCO2 of 40 and we drop it acutely and keep it at some new lower level. This is the bicarbonate starting off at 24. When we first drop the PCO2, we find the bicarbonate falls a little bit, and we'll show what that is quantitatively in a minute. We call that acute respiratory alkalosis. If we, however, keep the PCO2 down over days, we'll find that the bicarbonate keeps falling, even though the PCO2 has not fallen any further. It's the same as it was after its initial fall. It's a step change, but the bicarbonate follows this curvilinear curve until a new steady state is achieved. When a new steady state is achieved, we call that chronic respiratory alkalosis. We don't have a name for everything in between, like subacute or subsubacute. We just have acute and chronic, even though it's a continuous curve changing. The chronic change, or the change over time here, requires a kidney. If you don't have kidneys, ESRD patient, for example, it'll always look acute. So that's important because that you might expect temporally the process to have become chronic, but for that, you need to have normal kidneys for this to occur. And as I said before, to distinguish the three processes, again, for the second and the third, we also look at the change in the PCO2 versus the change in bicarbonate. We don't look at the pH. And so in acute respiratory alkalosis, just like chronic respiratory alkalosis and metabolic acidosis that's compensated, we have a drop in the bicarbonate and the PCO2. And our task is to see whether the delta PCO2 versus the delta bicarbonate fit now acute respiratory alkalosis. And if it was acute respiratory alkalosis, let's say I became suddenly anxious and hyperventilated, and my PCO2 dropped from 40 to 30 or dropped by 10, I would expect my bicarbonate to drop by 2. So for every 10 fall in the PCO2, you shift the bicarbonate buffer reaction that I showed before, such that the bicarbonate falls 2 from its original level. If the PCO2 falls by 20 and my PCO2 went from 40 to 20, let's say, my bicarbonate would fall from 24 to 20, fall double that amount. Okay, so for every 10, and that's very different than what we showed for metabolic acidosis, where for every 10 fall in the bicarbonate, the PCO2 falls by 12. This is very different proportionality. So it's easily distinguishable from a compensated metabolic acidosis, even though both parameters are down from their original level. If you see these kind of numbers, you would never think it could be a metabolic acidosis compensated. Now, chronic respiratory alkalosis. So again, we waited longer, and for the same change in the PCO2, the bicarbonate fell further, has a different rule. You can see here that for every 10 fall in the PCO2, the change in the bicarbonate is 5. So initially, from the bicarbonate buffer reaction, it fell 2. It falls a further 3 from that initial 2 due to the kidney. So the total change is 5 from the original level. So the proportionality here is 2 to 1. For every 10 change in the PCO2, the bicarbonate falls half of that. And again, you don't see that in metabolic acidosis where it's 12 and 10 here. They're approximately equal. Or do we see this in acute respiratory alkalosis where it's 10 to 2, 5 times difference here? There's a 2 to 1 difference in the changes. So you just have to memorize these so-called delta deltas, and that will allow you immediately to determine which of the 3 acid-base disorders it is, assuming it's a simple acid-base disorder. Okay, so again, we have the fall of 5 from its original level because 2 was from the acute respiratory alkalosis buffer reaction, bicarbonate buffer reaction, and the kidney, assuming there's normal renal function, dropped at a further 3. And how the kidney does that, we won't talk about today, but it is a renal process. Now, let's take the converse situation. Let's say you looked at the total CO2 and bicarbonate, like you should be when you're answering the question, what acid-base disorders does my patient have? And you find that the total CO2 or the bicarbonate, if you have it, is elevated. And again, like in the downside, we have 3 choices. So for both, we have always 3 choices. In this case, though, the first choice is a metabolic alkalosis as opposed to acidosis. Again, we have our acute and chronic respiratory acid-base disorders, but they're in the opposite direction. It's either acute respiratory acidosis or chronic respiratory acidosis. Again, in all 3, the PCO2 is elevated. So when the total CO2 or bicarbonate is decreased, the PCO2 is also decreased. And when the bicarbonate or total CO2 is elevated, the PCO2 is elevated. So the directionality of the changes doesn't help you. They all 3 have the same direction of change in both parameters. Again, to distinguish them, we don't look at the pH. We're going to have to memorize what the expected delta bicarbonate to delta PCO2 is for each of the 3 and see which one our patient has. So let's take metabolic alkalosis. Again, the bicarbonate's increased, but the PCO2 is also increased. We call that increase the respiratory compensation or the compensatory response. Remember that in metabolic alkalosis, which people tend to forget, there's also a compensatory response. It isn't just in metabolic acidosis. Both metabolic acid-base disorders have a change in your ventilation. And with metabolic alkalosis, it's the opposite. The PCO2 goes up because your ventilation decreases when you get a metabolic alkalosis. And the rule is different from the changes in metabolic acidosis. For every 10 increase in the bicarbonate, the PCO2 goes up by 7, doesn't go up by 12, which would be the converse of metabolic acidosis. It goes up less than the bicarbonate went up, about 0.70%. Whatever your bicarbonate went up, the PCO2 goes up 70% of that. So if this went up by 5, this would go up 3.5. This went up by 20, this will go up by 14. And again, you just have to memorize it. So if your bicarbonate, for example, went from 24 to 34 because you were vomiting for a few days, you would expect the PCO2 to go from 40 to 47. If you saw these numbers, you would say my patient has a compensated metabolic alkalosis. In metabolic alkalosis, we don't divide it up by the anion gap, but we further divide it up by whether the patient will have the bicarbonate return to normal if I give the patient a chloride-containing salt. We don't say we're going to give the patient saline to do it because more exactly, it's the chloride which is causing the return of the bicarbonate to normal, not the sodium that you're giving. It's the chloride that's physiologically causing the bicarbonate to drop to normal. So we have two groups. One group of patients where you started chloride intravenously or orally, and it did not correct, and the other where it corrected. You could do that empirical test and see what happens. But if you want to predict what's going to happen without giving the patient chloride, you can look at the urine chloride, and the urine chloride concentration predicts for you without having to do the experiment what will happen when you give chloride. So if the urine chloride is normal, and by normal it means what you would expect on that dietary chloride intake and that water intake, because we're dividing those two outputs, remember, to get the chloride concentration. You need to know both. But assuming the patient's drinking a normal amount of water and taking in a normal chloride amount, that will then result in a chloride concentration which is normal. That if you see that, then you know predictably that giving chloride to the patient will do nothing to the bicarbonate. You're not going to correct it. Whereas if the chloride concentration is low, that predicts for you that giving chloride will correct the metabolic alkalosis. So again, when we have a metabolic alkalosis, when you have that acid-base diagnosis, you can't just say my patient has a metabolic alkalosis. You also have to say the acid-base disorder, in this case, metabolic alkalosis, is compensated, and whether it's chloride sensitive or resistant based on the urine chloride. And then you'll have a complete diagnosis. Now, the bicarbonate or total CO2 could also be elevated because you have a respiratory acid-base disorder, which, remember, we always divide up temporally into acute or chronic. So don't just ever say my patient has a respiratory acidosis. You have to have the word before, either acute or chronic, always coupled to the word respiratory acidosis or alkalosis. In this case, the PCO2 has gone up, and then the bicarbonate follows by going up. So again, they're both up, just like in metabolic alkalosis, but the question is how to distinguish it. Again, we look at acute first, and acute respiratory acidosis is created by the converse of opening up the carbonated drink. Here, we're actually bubbling carbon dioxide into the solution and driving the bicarbonate buffer reaction to the right. And the same thing occurs in your body. If you hold your breath and stop the excretion of carbon dioxide, then you'll shift the bicarbonate buffer reaction to the right and generate bicarbonate. This has nothing to do with the kidney or organs. It's occurring in solution because of the bicarbonate buffer system. It takes about, again, 5 or 10 minutes. And again, we have an elevated PCO2 and we have an elevated bicarbonate. And we have to distinguish that from metabolic alkalosis. We call that acute respiratory alkalosis, but if we keep the PCO2 elevated in a step change over days, we find the bicarbonate keeps going up and up and up beyond what it did for the bicarbonate buffer reaction. And when it reaches a plateau, we call that chronic respiratory acidosis. And for that, we need normal kidneys also. This increase over time with an elevated PCO2 will not occur if you have ESRD or if you don't have normal kidney function. Even with CKD, depending on the CKD stage, this curve's going to look different for every CKD stage. People don't talk about that, but the normal response requires normal kidney function. So if you have no kidneys or no kidney function, it's always going to look acute, even though you've been out 3 or 4 days after the initial episode occurred. So how do we diagnose acute respiratory acidosis, this sudden increase in the PCO2? Again, we're driving the bicarbonate buffer reaction. That's what you should always think of when you hear the word acute. You're talking about the bicarbonate buffer reaction, not an organ. And for every 10 increase in the PCO2, the bicarbonate changes by 1. Remember, in the other direction, it's 10 to 2. So it doesn't quite go up as much in the up direction. In chronic respiratory acidosis, if I keep the PCO2 elevated for a longer period of time, it goes up further by another 2.5 or so due to the kidney, such that the total increase is about 3.5 from its original level. So if the PCO2 went up by 10, this goes up 3.5. If I hypoventilate for 4 or 5 days, such that my PCO2 has gone up 20 from its original level from time 0, the bicarbonate will go up by 7. So again, these proportionalities for metabolic alkalosis, acute or chronic respiratory acidosis all differ from each other. That allows you, once you memorize these delta deltas, to diagnose each of the 3 easily by just seeing what your patient did. So again, we distinguish temporally respiratory acidosis into either acute or chronic, depending on what time we are from time 0. And again, the PCO2 is not going up here and changing. It's a step change. It's kept at a constant level. The only thing that's changing over time is the bicarbonate. And if you plug these numbers into the Henderson-Hasselbalch equation, the pH obviously is changing. Initially, the pH changed the most, and as the bicarbonate keeps going up and up, the pH starts coming back down over time. What are some additional clues that respiratory acid-base disorders are present? And this is an important concept which fellows tend to need to be reminded of, and that is, and it's conceptually a little confusing, metabolic acidosis or alkalosis is present, but the predicted respiratory compensation is not present. It's not what you would predict. So let's look at this example. Let's say we have a patient with a bicarbonate of 14 due to diarrhea. We know it's a metabolic acidosis, at least causally. We'd expect the PCO2, if this decreased by 10, knowing our acid-base rule, we'd expect the PCO2 to drop by 12 if the ventilation was normal. That would be the normal expected compensatory response. If we had these 2 numbers, 14 for bicarbonate and a PCO2 of 28, we call this appropriately compensated. But what if it's not 28? It could be anything above 28 or anything below 28. And the concept is that if it's above 28, we call that a respiratory acidosis. So that confuses people. They go, how can you have a bicarbonate, let's say, or a PCO2, let's say, of 32 or 33? It's above the 28. It's 32, 33, but you're calling that a respiratory acidosis. It's below 40. Why is that a respiratory acidosis? And the point is that the new expected number is 28. And 28 becomes your new so-called dividing line to divide respiratory acid-base disorders from each other, or to make a diagnosis of a respiratory acid-base disorder. You do not use the 40 anymore. And so everything above 28 is a respiratory acidosis in red, and everything below 28, what if the PCO2 is lower than you would predict? The patient's ventilating even more than the compensatory response. And now we're in the yellow regime here. That would be called a respiratory alkalosis. Now, we don't call the PCO2 dropping to 28 a respiratory alkalosis or a secondary respiratory alkalosis like some people erroneously do. The compensation is normality, so we don't use respiratory alkalosis to talk about the fall in the PCO2 that one expects to get, because when you use respiratory alkalosis, you're saying that the fall it exceeds what you'd expect. You're implying abnormality. The fall that you expect is not called an acid-base disorder. So we don't call that respiratory alkalosis or secondary respiratory alkalosis. We call that the appropriate ventilatory response or appropriate compensation. But the point is that is now your new normal cutoff for when you have a respiratory acid-base disorder or not. So if let's say the patient had a bicarb of 14 from diarrhea and the PCO2 is 33 and you expect it to be 28, don't forget the patient has a mixed disorder. The patient has metabolic acidosis and a respiratory acidosis. So that's an important conceptual point, that the lack of the appropriate compensation means by definition you have a respiratory acid-base disorder in addition. Don't forget that when you're writing the acid-base diagnosis in the chart or you're taking your boards. And it's a clue that you have a mixed disorder when you don't have the appropriate compensation. It's insufficient to say that the compensation wasn't appropriate. You also have to think of that means that you must have a respiratory acid-base disorder. Either it was higher than you would expect, so you have a respiratory acidosis, or it's lower than you would expect, and you have a respiratory alkalosis in addition to the metabolic acidosis. So remember this important concept. The other important point is the rules that we use to diagnose these simple acid-base disorders. And by simple, I don't mean that they're simple physiologically or conceptually. I mean that there's not more than one. We don't have a mixed acid-base disorder. Each of these things takes time for the final numbers to be achieved. So for metabolic acidosis, it takes about half a day to a day for the compensatory response to be complete. If you come in before that, you're going to think there's a mixed disorder. So you have to be careful. You have to know roughly when it started. Metabolic alkalosis takes a bit longer for the PCO2 to reach the compensatory level that we expect, 70%, remember, of whatever the bicarbonate went up by. Acute respiratory acidosis and acute respiratory alkalosis are very fast. That's just the bicarbonate buffer reaction. And the chronic changes, which requires a normal kidney, take longer. It takes about 3 to 5 days for the bicarbonate to stop not going up, additional to the acute changes in chronic respiratory acidosis. The steady state for chronic respiratory alkalosis is achieved a little bit earlier. So again, metabolic acidosis, we divide up by anion gap. Metabolic alkalosis, we divide up by whether the urine chloride is normal or decreased so that we can predict whether it's going to respond to giving chloride or not. Respiratory acidosis, we divide up into acute or chronic, similar to alkalosis. We divide these up by time. So here are some interesting cases now. Let's look at this case. 27-year-old male diabetic with 4+ ketones in the urine. We are asked to make an acid-base diagnosis. We look at the total CO2 or the bicarbonate. We don't look at the pH. We focus on these two numbers since we have both. And again, they're both down. And we know we either have a metabolic acidosis or we have acute or a chronic respiratory alkalosis. It's the only, we have 3 acid-base disorders which are going to lower the bicarbonate or the total CO2. So now we look at the change in the bicarbonate versus the change in the PCO2. And we have to assume what the normal levels are. We don't know for sure, so we use population means. We assume this should have been around 40 and this should have been around 24. And so this fell by about 12 and this fell by about 10. So of the 3 acid-base disorders, the only one that you get those delta changes in is in a compensated metabolic acidosis. So, and we have a glucose of 800 here, but it's interesting, the anion gap is 11. And that's surprising. We'd expect, if this is ketoacidosis, we'd expect the anion gap to be elevated. So we have what looks like diabetic ketoacidosis as a cause, but we have a non-anion gap blood chemistry picture. So the acid-base diagnosis, because of these deltas, is only compatible with a compensated metabolic acidosis. But the blood chemistry picture, when we now further want to subdivide this into anion gap or non-anion gap, looks like a non-anion gap picture here, where when we calculate the anion gap, you can see you get 11 here. And that's surprising. We'd expect it to be elevated. We know the cause of the acid-base disorder physiologically is most likely an anion gap metabolic acidosis. So we have to now try to figure out why the anion gap is not elevated. So why is the anion gap normal is the key question in this case. Well, remember that everything is dynamic. We have an input and output of everything we measure in nephrology. We don't just have an input or an output. You have both in the real world. So the metabolic acidosis is caused by the proton coming in this case with ketones, beta hydroxybutyrate or acetoacetate, that's the anion, and that should elevate the anion gap. But remember, we also have an output of anions, and the output is the kidney. And so if we have a situation where the output is matching the input from time zero, the anion gap will never go up. And that's an important point, is important to remember in anion gap metabolic acidoses, that the anion gap is not just a reflection of what came into the body, it's a reflection of what's leaving via the kidney. And there was a paper a number of years ago showing that the anion gap in ketoacidosis depends on what the BUN is. They didn't use the creatinine here. But the bottom line is that the anion gap varies with the GFR. And the reason is the GFR is a very important determinant of what the excretion is. So the more euvolemic you are and the more normal your GFR, the easier it is for you to be able to excrete the anions in the urine, and they just won't go up as much in the blood. And if you're excreting what came in from time zero, they'll never go up. And what happens is chloride goes up for electroneutrality reasons. So you end up with a normal anion gap. So this is a very important point that the anion gap in ketoacidosis doesn't just vary with the input of organic anions into the blood. It also varies with the output. And you can actually get whatever anion gap you want for a given input, which I'll show in a minute, depending on your GFR. So the anion gap can be any value in ketoacidosis for a given input. And you also have to think of both the renal excretion and the input when you're assessing the anion gap, which people tend not to do. And because of that, you cannot use the anion gap to assess the severity of DKA in the presence of a decrease in GFR. And people tend to do that, whether they're going to keep them in the ICU or not, or the severity of the ketoacidosis. You hear the talk like that all the time in the hospital, that the anion gap is sky high, so the patient must have rip-roaring ketoacidosis. Well, it may be that their GFR is horrible and they're just able to elevate the anion gap more easily. So this is shown pictorially here. For a given fixed input rate of ketones, patient 1 has a normal anion gap and is euvolemic, whereas patient 2, let's say the extreme ESRD, no GFR, has a very elevated anion gap. Both have the same magnitude of ketoacidosis. The anion gap, though, is extremely different. So remember that for the rest of your careers, that the anion gap in anion gap metabolic acidoses varies with what the kidney's doing also. And it's always worse as your GFR decreases. So either you have ESRD or you have severe hypovolemia from the osmotic diuresis or vomiting. Those patients are going to have a more elevated anion gap. And again, it's reversible. Sometimes you'll have a patient who's hypovolemic and you give them saline and you'll see the anion gap get better. And the reason it's getting better is you're not shutting off the ketoacidosis. It's getting better with the saline because you're allowing the kidney to get rid of the anions. And you'll find that the anions end up in the urine. The anion gap in the anions, the ketones in the blood are normal or very low, but in the urine they're very high. So you always have to think of the dynamic changes too. Obviously, if it's ESRD, the anion gap will not be dynamically changing with volume. But if you have someone with pre-renal failure and now you give them volume and the GFR improves, your anion gap improvement could be the reason, or the excretion of anions in the urine could be the reason the anion gap falls. So don't attribute that to the ketoacidosis getting better. Now, it's important as far as the acid-base disorder because the ketones are actually a source of bicarbonate. So patients, paradoxically, who are euvolemic and are able to excrete the beta-hydroxybutyrate and acetoacetate in the urine actually take a lot longer to correct their metabolic acidosis because they've lost the source of bicarbonate. Whereas patients who have a higher anion gap, such as patient number 2, because they can't excrete the organic anions, actually correct the metabolic acidosis sooner because they have these organic anions floating around. Okay, so this is a woman in the 3rd trimester of pregnancy. Again, what numbers do we look at? We look at the total CO2 and bicarbonate. We find they're down. Again, that means we have one of 3 acid-base disorders, metabolic acidosis or acute or chronic respiratory alkalosis. And again, and I'm not showing the pH here on purpose. Again, to make the diagnosis, we look at the delta bicarbonate versus the delta PCO2. And again, this just shows you the proportionality of the two and how they determine the pH. So if you know these two, the PCO2 and bicarbonate, you know the pH anyway. You don't have to see it. But again, leaving it out just emphasizes the point of not focusing on the pH to make the diagnosis. And so it's a woman, so remember that the PCO2 and bicarbonate are not 40 and 24, around 37, 38, and 23 or so to start. So the deltas are a bit different. And so this bicarbonate fell by about 9 from its original level. And the PCO2 fell by about 18. The original would be 38. So we have a 2-to-1 proportionality here in the changes. Again, the pH must be 7.47 when you plug these two numbers into the Henderson equation. This is the non-log form of the Henderson-Hasselbalch equation where the constants have been lumped together to get the 24. So again, we have a PCO2 that fell by 18 and a bicarbonate that fell by 9. This is only compatible with chronic respiratory alkalosis. It's not compatible with metabolic acidosis where we have a 12 to 10 proportionality here. This is 2-to-1 where the PCO2 has fallen twice as much as the bicarbonate. That's only compatible with chronic respiratory alkalosis. And again, it's something that took time to create. The initial fall was from the bicarbonate buffer reaction, but because the patient has normal kidneys, the initial fall is due to what the kidneys are doing, and the total change in bicarbonate was 9 from its original level. And this is what we see during pregnancy. If you look at the acid-base numbers in the 1st, 2nd, or 3rd trimester of pregnancy, these patients have a chronic respiratory alkalosis, and it's felt to be potentially due to progesterone driving the respiratory center. But you can see at each of these stages, there's a 2-to-1 difference that for every 10 fall roughly in the PCO2, the bicarbonate's fallen by around 5 or so. So there's a 2-to-1 proportionality. That's what you see in chronic respiratory alkalosis. Other causes of chronic respiratory alkalosis are people that live at high altitude from hypoxia driving the system, end-stage liver disease, which we see here a lot in the UCLA, and emphysema. All these patients have chronic respiratory alkalosis. Here's another patient with a panic attack. And again, we look at the bicarbonate and the PCO2, and first we look at the total CO2 and bicarbonate and answer, are they elevated, normal, or decreased? They're both decreased, so it's either, again, metabolic acidosis or acute or chronic respiratory alkalosis. And then we look at the PCO2 and calculate the deltas from normality. And you can see here that the bicarbonate's fallen by about 4 and the PCO2 is down by about 20 from its original level. So it's a 10-to-2 proportionality, which we only see in, again, just showing you the pH and calculating what it was from the Henderson equation. We only see this in acute respiratory alkalosis. The PCO2 has fallen 20, the bicarbonate's fallen by 4. This is the only acid-base disorder that you get these two deltas in. Now, There's other clues that it's acute respiratory alkalosis that are not in the acid-base numbers. One is that the patient has an elevated anion gap and the phosphorus is 2. So if you see this, a slightly elevated anion gap and a low phosphorus, it tells you also it was likely acute. When you get chronic respiratory alkalosis, these numbers normalize. So without having a good history or without knowing what the numbers were before, how long this has been occurring, a clue on an exam or in the real world would be that if it's acute, the anion gap's up a little bit and the phosphorus is down. So the question is, why do these occur? Well, one of the reasons is whenever you get a change in pH, you shift the protonation of albumin. And remember, albumin contributes to your anion gap. It's a buffer. So if you, for whatever reason, alkalinize or acidify the blood, you're going to change the protonation on albumin, which will then change its charge. And that charge contributes to the anion gap. For every 0.1 change in pH, the anion gap changes by around 0.15, small amount, due to changes in albumin, the charge on albumin. So in all the acid-base disorders, whenever the pH changes for whatever reason, you change the anion gap because of the charge on albumin changing. And the same thing is occurring here. The pH went to 7.67 from 7.4, and that's going to deprotonate albumin and increase its charge. So that's one reason the anion gap went up. The other reason is phosphofructokinase. This is the glycolytic cycle in intracellularly that makes lactate from glucose, proton with lactate. Phosphofructokinase, one of the key enzymes in glycolysis, is very pH sensitive. And whenever the cell pH alkalinizes, you stimulate glycolysis. So when you acutely hyperventilate, and you not only raise your pH in your blood, you also raise your pH intracellularly. And that stimulates glycolysis and generates lactate with protons. So you get a mild lactic acidosis every time you hyperventilate. And that also, the lactate going up contributes to the elevated anion gap. In chronic respiratory alkalosis, the pH tends to recover closer to normality. In fact, it can be very close to normal. It's one of the few acid-base disorders where you can end up with a pH which doesn't look much different than normal. And there, the intracellular pH returns to normal, and so the glycolysis is shut off. And also albumin doesn't deprotonate when the pH is closer to normal, and so you don't have the anion gap elevated either. The other thing that this does is by stimulating glycolysis, phosphate enters the cell to phosphorylate these glycolytic intermediates. And so you end up dropping your extracellular phosphate concentration. It's a very good way to drop your phosphate. If you acutely hyperventilate and measure your serum phosphorus, it drops very quickly as phosphate enters the cells. And so it's just, again, the same reason you're stimulating glycolysis. You end up with a low extracellular phosphate, a higher lactate level than normal, and an increase in your anion gap. So those are clues in acute respiratory alkalosis. Here's another patient here with a chronic productive cough. Again, we look at the total CO2 or the bicarbonate, and they're elevated. So we're either dealing with a metabolic alkalosis or acute or chronic respiratory acidosis. The bicarbonate's gone up by about 11. The PCO2 has gone up by about 32. And again, we can put these numbers into the Henderson equation and calculate the pH. But these deltas are only compatible with chronic respiratory acidosis. They're not compatible with metabolic alkalosis or acute respiratory acidosis. Again, the proportionality is 10 to 3.5. So if the PCO2 changed by 32, you'd expect the bicarbonate to go up by 11. This is what you would see in someone who's chronically hypoventilating. And again, there's a temporal curve here that you see when you raise the PCO2, the bicarbonate goes up acutely just from driving the bicarbonate buffer reaction. But if you keep following the patient and they have normal kidneys, the bicarbonate's going to go up for every 10 increase here by 3.5. Or in our patient, this went up by 32. So this would go up by 11 from its original value. The other thing you have to think of when you have a patient with chronic respiratory acidosis is what's the PO2 in the alveoli? Because remember, um, there's a way of calculating what the PO2 is in the alveoli and comparing that to blood to calculate the so-called AA gradient. It helps us distinguish the cause of the elevated PCO2. So on room air, it's 150 minus 5/4 of whatever the PCO2 is. We get an answer of 60. That means the PO2 in our patient's alveoli was 60. And if in our blood it's 50, that means the difference is 10 and we have a normal AA gradient. The patient's hypoxic, not because there's a problem with transfer of oxygen into the blood from the alveoli, but because the alveoli themselves started off with a lower PO2 than normality. And that helps us distinguish the two common causes of chronic respiratory acidosis. We either have what's so-called blue bloater or the pink puffer. The blue bloater and pink puffer have totally different acid-base disorders. The blue bloater, the chronic bronchitic, has chronic respiratory acidosis, and they're hypoxic because the PO2 in the alveoli start off being low, like I just showed. Whereas the emphysematous patient has chronic respiratory alkalosis, and they're hypoxic not because they have a problem with a low PO2 in their alveoli. In fact, their alveolar PO2 is above normality, but they have a high A gradient, and they have parenchymal lung disease, which prevents the transfer of oxygen from the alveoli to the blood. So the A gradients, when you have chronic respiratory acidosis as an acid-base disorder, always calculate the A gradient also and discuss that in your consult note. So remember, these people have a normal A gradient and these people have an elevated A gradient. Okay, and I think I'll stop there for today. So again, the take-home points are when you're making an acid-base diagnosis, focus on, from all the numbers that can confuse you, the total CO2 or the bicarbonate, and answer, is it normal, increased, or decreased? If it's decreased, you have one of three acid-base disorders. It's either a metabolic acidosis or acute or chronic respiratory alkalosis. And if it's elevated, it's either metabolic alkalosis or acute or chronic respiratory acidosis. And for each of those three, whether it's up or down, so we have 6 total, memorize what the deltas are and see for your patient, which you first divide it by whether it's up or down, and that gives you a choice of 3 for each, and then see what your patients are and fit them in. If it doesn't fit into one of the 3, then by definition, you have a mixed acid-base disorder. You don't have just one of those 3 as a simple acid-base disorder. You have more than one acid-base disorder present. So the lack of being able to fit it into the 3 doesn't mean you made a mistake. It just means that the patient is more complicated and there's more than one acid-base disorder present. And we'll talk about that in future talks. What I didn't talk about today also is another concept that if the number is normal, and this is something they'll give you on your boards, if the bicarbonate is 24, it doesn't mean that there's no acid-base disorder present. Remember that we're always looking at the net of multiple processes. So it's very possible that you have a patient who's vomiting with diarrhea, and the vomiting would tend to raise the bicarbonate, let's say by 5, and the diarrhea would tend to lower it by 5, and you end up with a bicarbonate of 24. But it doesn't mean that you don't have 2 acid-base disorders present, and there's ways to try to figure out those processes also. So it's another important take-home message that the lack of a change in the bicarbonate or total CO2 doesn't definitively rule out acid-base disorders present. And more globally, it brings up the process that whenever you're looking at these numbers, you're always looking at the net sum effect of multiple processes that could be present. It could be there's nothing present, in which case you don't have an acid-base disorder. But whenever you have something present, you're always looking at potentially more than one process. And so it's the net effect of these processes. And then remember also anion gap, and not just anion gap, but anything we measure in nephrology is the result of input versus output. It's not just the input or the output. And that's what determines the final concentration in your blood. And the anion gap is a beautiful example of that, where people tend to focus only on the input side, but ignore the fact that the anions are coming out in the urine. that also determines what the final concentration is. It's the same type of concept as a patient, let's say with lymphoma, or some reason for calcium input into the bloodstream. You can't ignore what's coming out in the urine. So if you have an input of calcium for whatever reason, but the urine's getting rid of it at the same rate, you can be normal calcemic, but all the calcium's in the urine. It's the same sort of process. You have hypercalciuria, but you have normal calcemia just because the kidney is keeping up with the input. So remember input versus output in this and other contexts that have to do with fluid and electrolyte analysis. Okay, everybody, that's what I had to say for today, and we'll carry on next month with complex acid-base disorders.
Thank you.